Hello, namaste everyone. I am Dr. S. Jayaraman, Senior Consultant Pulmonologist, MGM Healthcare, Chennai. Tomorrow, August 1st, every year, as per the WHO recommendations, we do the awareness activities to commemorate World Lung Cancer Day. So, August 1st is the World Lung Cancer Day. You know well, in the world scenario, lung cancer is an important common cancer among the cancers, morbidity and mortality. If you take an Indian scenario, in male population, this is the second leading common cause of mortality, that is a death rate. And in female population, this is the fourth leading cause of death among the cancers in the female populations. Throughout the Western world, because of the smoking, the lung cancer is the number one, even men and women. So the second cancer in female is the breast cancer. But in the world scenario, the lung cancer is the number one cancer, predominantly affecting the men and women because of the smoking habits, mainly the tobacco. So lung cancer is such a vast majority of the sufferings because the lung cancer diagnosis is slightly difficult because of the presentation, very, very difficult. So every year, to create awareness among the lung cancer diagnosis and treatment, to catch early and treat early, to have a very good life for the patients. So to commemorate World Lung Cancer Day, myself, pulmonologist as a lung specialist, and my colleague Dr. Suresh, medical oncologist, senior consultant working in the MGM Healthcare, is taking care of oncological treatment, mainly the chemotherapy and the radiation therapy, etc. So now we are going to brief about the lung cancer incidence and how to diagnose the lung cancer from the symptomatology, symptoms of lung cancer. First, what is lung cancer? So lung cancer is a very common cancer among the cancers. The symptomatology of lung cancer are very, very important. See, there are three presentation of lung cancer. One third of the patient, they usually present with the local symptom, that is lung symptoms, mainly cough and blood while coughing, weight loss, and sometimes the breathing issues, chest pain, etc. And the remaining one third of the patient, they present with the advanced symptoms, that is metastatic symptoms, that is a cancer spread from lung to brain, liver, bones. They present with the jaundice, fits, seizure disorders, and the bone pain. And the remaining one third of the patient, without any symptom, silently they will act. So incidental findings, when you take the chest radiography for the routine master health checkup or pre-employment checkup or any checkup to take the chest x-ray, incidentally you can pick up some lesions, some white color opacities in the chest radiography. Then we suggested for CT scan. CT scan shows some speculated margin suggestive of malignancy. Then biopsy and confirm the diagnosis. This is the way three presentation of lung cancer clinical symptomatology. One present with the direct symptoms of cough and blood while coughing and chest pain, breathing difficulty, and remaining one third they present with the metastatic advanced symptoms, and remaining one third without any symptoms. The incidental finding in the radiography, then confirmed by the CT scan and biopsy. This way we diagnose. So now I'm asking my friend Dr. Suresh one question. What is his experience in a clinical presentation? Because majority of the patient, they directly come to the lung specialist or general physician, or directly they go to the cancer specialist also walk in line. So I asked my friend Dr. Suresh about the presentation of lung cancer in his experience.
Good evening, everyone. Thank you, Jayaraman sir. So, as sir has said, the presentations can be different for each individual, and most of the patients will be presenting to the family physician first. So, irrespective of whether they have cough or blood in the sputum or difficulty in breathing or any bony pain, the first member to have an opinion will be the family doctor. So after the family doctor sees them, and then they'll be asked to do some battery of investigations from blood tests to imaging with X-rays or CT scans or MRI. So only after the diagnosis, the patient comes to an oncologist. So we are an end specialist, and most of the times it is a referral from the family physicians or the pulmonologist. And when the patient comes to us, it is most commonly with the evidence of cancer, either with imaging or a biopsy proved confirmation. And when the patient comes to us, it can be in a different stages from stage 1, 2, 3, and 4. The idea behind staging is to know what type of treatment the patient will get benefited from. So before staging, there should be a biopsy. Without biopsy confirmation, we will not be able to know whether there is a cancer. And after a biopsy, we will be having different types of lung cancer. It is most commonly divided into small cell lung cancer or a non-small cell lung cancer. Even in non-small cell lung cancer, it can be adenocarcinoma, a squamous cell carcinoma, or a large cell neuroendocrine tumor. So these are all the types which we can have in non-small cell lung cancer. So without a biopsy, it will be very, very difficult for us to proceed further with treatment. Now, for biopsy, sir, what are the options the patient will have, and how do you do a biopsy, sir?
Yeah, Dr. Suresh is well said about the biopsy. So without biopsy positive report, they won't start any treatment. So biopsy is very, very important. So tissue is the issue in the diagnosis of lung cancer. Once you diagnose a lung cancer family with a firm diagnosis of lung cancer with a biopsy proven, biopsy means histopathological evidence. So after that only we can plan the treatment. The lung cancer treatment varies based on the stage and other thing. Before that, we have to confirm whether the patient has a lung cancer or not. In our country, the diagnosis of lung cancer is challenging. Not only in India, throughout the world, it's challenging only because in India we have a lot of tuberculosis patient, pulmonary tuberculosis. It mimics cancer. Our cancer can mimic tuberculosis. These two diseases we have to correctly confirm whether we are dealing with the tuberculosis or the lung cancer. Tuberculosis and lung cancer symptomatology more or less same. Cough, blood while coughing, chest pain, breathing issues, and weight loss, loss of appetite, fever. One type of cancer called the bronchoalveolar cell carcinoma. This cancer also present with a pneumonia type and feverous type. So sometimes it's very difficult without any positive evidence of a biopsy proven. So how to confirm whether patient has cancer, lung cancer or not? So we have a very good tool called the bronchoscopy. After the CT scan, we know that we are dealing with the mass lesion. Mass means there is a tumor in the lung. So how to diagnose before sending the patient to the oncologist like radiation and medical oncologist. So we have an important tool to diagnose lung cancer is the that is a bronchoscopy. Bronchoscopy is an important instrument to diagnose the lung cancer. So bronchoscopy is nothing but is a airway endoscopy or lung endoscopy. It's a type of endoscopy of the lung, that is a bronchoscopy, which examine the airway, that is a trachea and bronchi we examine. There are two types of bronchoscopy. We have a basic bronchoscopy, fiber optic video bronchoscopy, and we have an advanced bronchoscopy like a EBUS bronchoscopy. EBUS means a endobronchial ultrasound bronchoscopy. So bronchoscopy is a very important tool to diagnose without any complications. So we can reach the diagnosis within 2-3 days time. We can achieve the full-fledged histopathological confirmation by bronchoscopy and biopsy. Biopsy means a tissue diagnosis. If you see any tumor endobronchially during bronchoscopy, bronchoscopy is a procedure, is an invasive clinical procedure, mainly to diagnose the lung cancer. This procedure can be done as an outpatient or daycare procedures under local anesthesia with a monitored anesthesia care. That means we'll give a mild IV sedation to smooth the procedure. To comfort the patient, we do the procedure in the bronchoscopy suite or in the operation theater. We do it under local anesthesia with IV sedation. Will be a 6 hours nil per oral. So with that, we enter into the lung through nose or mouth. We'll pass a small flexible tube, and with the camera attachments in the video, and we'll examine the breathing passages like trachea and bronchi and the secondary bronchiole and all. So during the bronchoscopy examination, we can see any tumorous form or any unhealthy mucosa. If there is any unhealthy mucosa or any tumor, we take a biopsy, that is a solid tissue biopsy. We take 3 to 5 samples. And we took a brushing also from the areas, and we take a liquid lung biopsy over the tumorous area. We collect all the samples like a bronchial wash and bronchial brush and endobronchial biopsy. These specimen, we subject him for the histopathological and immunohistochemistry and further immunomolecular diagnostic test to find out what type of cancer. Already Dr. Suresh said there are two types of lung cancer. One is the small cell lung cancer, other one is the non-small cell lung cancer. In non-small cell lung cancer, there are several types. Squamous cell carcinoma is the very commonest one, and adenocarcinoma, large cell carcinoma, etc. And in small cell also, there are limited variety and extensive variety. So we have to find out the correct what type of a cell, whether is it a small cell or non-small cell, whether is it adenocarcinoma or squamous cell carcinoma, or is it a neuroendocrine carcinoma or small cell carcinoma. Pathological examination under the microscopy and various stain examination, we can pick up what type of cancer, what type of cells, and what type of treatment we are going to offer, everything. So we know that. Once we diagnose the lung cancer by bronchoscopy method, if sometimes you are not able to see any tumor in the endobronchial, bronchoscopically you can't able to see any tumor, then we do the endobronchial ultrasound. This is a type of advanced bronchoscopy. We put the endoscope, that is a bronchial ultrasound, and see the lesion and take the biopsy through the bronchial wall, to pierce the bronchial wall and take the biopsy, and we take a liquid lung biopsy. So in that bronchoscopy method, we can diagnose the lung cancer 100% firmly with the cell type and all. Once you diagnose the bronchoscopy, we refer the patient to tumor board. I request Dr. Suresh sir will tell about what is tumor board, what are the types of activity we do it in the tumor board. Over to Suresh sir.
Thank you, sir. So as sir has been saying, biopsy with an bronchoscopy is one of the main thing. So when we see a mass in the lung, we will be dividing that into a central lesion and a peripheral lesion. Central lesion is whatever is near to the windpipe and to the heart structures, and peripheral lesion is which is closer to the chest side walls. So bronchoscopy will be easier to access the tissue lesions which are in the central lesions. And if it's going to be a peripheral lesions, and if you're not able to reach those lesions with the help of bronchoscopy, then we will be going with a CT guided biopsy. So once we get a biopsy and the disease is confirmed, now we will be doing a PET scan. So PET scan has become the standard, and deciding on whether what will be the treatment options. PET scan will be from head to foot. It will be a complete imaging of our body, and will be telling about the disease, whether it is confined to the lungs alone, confined to the chest, or as it spread to any other disease, any other site, as Dr. Jayaraman sir was saying, brain, other parts of the lungs, bones, liver, or any other region which can be involved with the lung cancers. So depending on this, we will be staging the disease. Stage 1, if it's confined to the lung alone. Stage 2, if it is lung alone and nearer to the main airway. Stage 3, yes, if it is in the lungs and involving the lymph nodes in the chest. Stage 4 is which has spread beyond the chest wall, that's from the lung nodes to different organisms. So with the complete diagnosis of a biopsy and the staging, then we go with the tumor board discussions. Tumor board essentially is we'll be having surgical oncologists, radiation oncologists, medical oncologist, a pulmonologist, a pathologist, a radiologist, and we have other persons who will be able to take care, like physiotherapist, occupational therapist, speech therapist. So these are all will be there, and we will be having a one-to-one discussion about the staging, about the patient and the patient's general condition, and what type of treatment will be appropriate for the patient and for the stage what he has. So apart from this tumor board, we will be doing several tests in the lung cancer biopsy itself. So whether we have an adenocarcinoma, squamous cell carcinoma, or a small cell carcinoma, we will be going beyond knowing the broad diagnosis. We want to know the genetic pathology which is driving this cancer. So the genetic driving mutations can be many. Can be as EGFR mutation, ALK mutation, ROS mutation, and MET exon 14 mutations, NTRK mutations, BRAF mutations, KRAS mutations, or HER2 mutations, and now we have the latest what is called as PDL1, whereas immunotherapy is indicated. So with all this information, biopsy, any driver mutations you have, and the staging, then we discuss with the tumor board. If the patient is having a stage 1, we will be going ahead with surgery if possible. Stage 2 needs more than one modality of treatment. Either it will be surgery with radiation or surgery with chemotherapy or chemoradiation. Any combinations will be there. And coming to stage 3, we have 3A, B, C, and we will be having a combinations of these factors, wherein surgery can be a part of this, but initially it will be chemotherapy and radiotherapy upfront. And if the patient shows very good response, then we can think about radiation surgery. Coming to stage 4 disease, that's a metastatic disease, which means a single modality like surgery or radiation, which acts only on the local region, may not be sufficient, and the patient has to be treated with chemotherapy. So these are all the treatment options. I would like to ask Jayaraman sir, because the most confusing things and the patients who are afraid of is doing a biopsy. Will biopsy lead to a spread of the disease? So that's what the people are afraid. Whenever we say do a biopsy for confirmation, they are afraid, say it might spread. But without a biopsy, we may not be able to proceed further with treatment. So what are your take on biopsy, sir?
Yeah. See, some of the patients, they are afraid to take the, allow us to do the biopsy. So we educate the patient about the role of biopsy to clinch the diagnosis of lung cancer. There are so many diseases can mimic lung cancer. Tuberculosis can mimic lung cancer. Lung cancer can mimic the tuberculosis. There are various differential diagnoses of clinical symptomatology. That's why we are struggling with the even though the incidence prevalence are very high in the world scenario and Indian scenario of lung cancer is the very highest morbidity and mortality, death rate is very high in lung cancer. This is the number one cancer. So biopsy is very important. Without biopsy, they cannot proceed with the whether chemotherapy or radiotherapy or surgery. So Dr. Suresh already well said about the treatment modalities based on the biopsy result and the cell types and the genetic driver mutations and various other subcategory. Then only we can assess the stage properly. For the staging purposes, after the biopsy, we need to do the whole body PET CT scan. This is a cancer scan to diagnose where is the lesion exactly, whether is it a localized lesion or spread to anywhere else like liver, bone, and the brain and all. So if it is a localized lesion, if it is non-small cell cancer, so the treatment modality will be the surgery. Sometimes this will be curative for the lung cancer. But the 25% of the people only we do the curative resection by the lung cancer surgery. Remaining 75%, they have to enroll in a chemotherapy and radiation therapy and targeted chemotherapy and lot of treatment modalities. If the patient has a lung tumor with the mediastinal lymph nodes, again we do the staging by using the advanced bronchoscopy like EBUS bronchoscopy. We tell the patient such a way, we educate the patient, because doing the biopsy, it won't spread the disease through the needle tract malignancy and all, very, very less possibilities. So the bronchoscopy biopsy is one of the important tool to clinch a diagnosis, whether we are giving the medical treatment or a surgical treatment or radiation treatment. So biopsy is a very, very important thing. There is no pain at all. So we are doing a biopsy test under the anesthesia, monitored anesthesia care, without pain, without the struggling. We are doing the biopsy. The report will come quickly within 3 to 5 days. If you do an immunohistochemistry, the report will come maximum 7 days. We get all the reports. Based on the report, we proceed. So previously, for lymph node sampling from the mediastinum, we rely on the thoracic surgeon to do the mediastinoscopy and take the sampling. Nowadays, we have advanced bronchoscopy like endobronchial ultrasound bronchoscopy. We can put the bronchoscope under anesthesia. We take the biopsies to the tracheal wall and the bronchial wall to take the biopsy without any complications of any bleeding, infections, or the pneumothorax at all. So this way of staging biopsies and the cellular this cell type all very, very important for the treatment purposes. So once you diagnose everything, we assess, we send the patient to tumor board, and in the tumor board meeting, we discuss everything, and we'll tell the patient attended. So these are the ways of treatment we are going to offer based on the stage and cell type. Then the patient will understand, yes, this type of treatment will give a much quality of life and all. So surgery is the very good treatment for the non-small cell cancer, stage 1 and stage 2 and stage 3A also. And remaining patients, we do a radiation therapy and chemotherapy, adjuvant chemotherapy before surgery to downstage the tumor, and we'll go for the surgery in the case of non-small cell. And I'm asked one question to Dr. Suresh regarding the role of targeted therapy and immunotherapy. What is immunotherapy and what is targeted chemotherapy?
Yes, sir. So, as I have been telling that there will be driver mutations in these cells. Most of the adenocarcinomas can have a driver mutations. Driver mutations is a sense patients will be asking, sir, what caused my cancer? So, the most common cause for cancer is smoking, yes. But beyond smoking, there will be some changes in our body. It's a genetic things which can change from a normal cell to an abnormal cell. This change can happen in the things which I had elaborated earlier, like EGFR, ALK, ROS, MET, KRAS, NRAS, PDL1, and HER2. So, NTRK. So, these are the different driver mutations which can change a normal cell to a malignant cells. And when we are able to have a biopsy, we will be able to do all these driver mutations called by a test called NGS, next generation sequencing. So with the help of this, we will be able to identify what is the genetic mutations which has caused this cancer to occur. And when we know this is the genetic problem, we will be able to attack those specific cells. Like if there is EGFR, then we have 4 different molecules like erlotinib, geftinib, osimertinib, afatinib. And if it's going to be ALK positive, then we can have crizotinib, ceritinib, alectinib, abricatinib. So each molecules will be there for a specific genetic problem. So whenever we have a driver mutations in this patient, we will be able to give a targeted therapy. So we have medicines which will target this driver mutations. This is what the targeted mutations are there. Even though those targeted mutations will not be as complicated or as having more side effects like a conventional chemotherapy, they do have some side effects which can be easily monitored. Coming to immunotherapy, which means our body, when there is a development of cancer, our immunity will be suppressed. So this can be found out by a test called PDL1 test. The patient has gotten PDL1 positivity, then we will be able to give a medicines immunotherapy, which when given will try to inhibit the cancer cells, suppressing the immune cells, and will come out of the shell. So the immune cells which have been inhibited by the cancer cells will come out and then gets to attack the cancer cells. So this is called immunotherapy, and this is the latest magic bullet which we have in our armamentarium.
Thank you, Suresh. Very well explained about the immunotherapy and the targeted chemotherapy. So all the facilities are available in MGM Healthcare, Department of Pulmonology and Department of Oncology. We do all the biopsy procedures, including a basic bronchoscopy and advanced bronchoscopy, and all the scanning facilities available here. And we have medical oncologists and radiation oncologists and surgical oncologists to do all type of surgeries, including a lobectomy. So the lobectomy in a stage early cancer lung, if it is a non-small cell cancer, this is a curative form of surgery. So in this MGM Health Center, we have all full-fledged department called cardiothoracic surgery to remove the tumor by doing the VATS lobectomy, that is video-assisted thoracoscopic surgical lobectomy. And we do all advanced technologies to cure the patients by, with the help of Dr. Suresh, oncologist, we have immunotherapy and chemotherapy and all. So, see, the lung cancer, that's why we are all struggling. In many other places, the malignancy can mimic other diseases. That's why a lot of struggling, the incidence and prevalence rates are very high in lung cancer, even in the Western world. That's why in the Western world, like Europe and American, the number one cancer among the men and women is the lung cancer. So next is the head and neck cancer and CA breast in female. CA cervix in India is very, very common in female populations. But overall, the common cause, what is the main culprit behind the lung cancer? So 10 to 20% there is a genetic predisposition, and majoritarily this is environmental factors, mainly the smoking, tobacco, which causes the cancer. This is the number one cause, number one culprit behind the lung cancer. and remaining in the other environmental exposures like the toxins, mainly the carcinogens, mainly the ionizing radiation, nickel, asbestos exposure, work-related. So these are the common conditions. So these lung cancer day, so every year we do a lot of awareness program to create awareness among the populations to detect the disease early. That's why the master health checkup, to pick up a lot of silent diseases in the X-ray and CT scan and further diagnosis to confirm the diagnosis of lung cancer. So the preventive medicine department is very, very important to pick up the diseases. We get so many referrals from the preventive medicine department to ask suspicious of cancer, please go ahead to the bronchoscopy and all. So we do bronchoscopy. Once you stage the diseases by PET CT and other advanced bronchoscopy, we refer the patient for the tumor board meeting. In the tumor board, medical oncologists and surgical oncologists and radiation oncologists, pulmonologists, radiologists, pathologists will sit together and discuss what type of treatment we are going to offer to the patient. Then we tell the patient and attenders, this are the program which will help the patient to improve the quality and cure sometimes also. So with this lung cancer awareness every year, these are all the struggling. It's a very common disease. It's a certain factor is preventable also. If it is smoking and all, very less countries like Sweden and other countries, there is less incidence of cancer. We take the European and American, because of the large habit of smoking, this lung cancer is very, very high. So we have a smoking cessation clinic in this hospital. We do all smoking cessation program, and we have a lot of programs, awareness activities going on in MGM Healthcare, Department of Pulmonology and Oncology. We do a regular screening and regular medical checkup, regular camp to create awareness among the populations about these smoking hazards. Myself and Dr. Suresh, we do programs. So this way we can pick up and create awareness among the lung cancer. The purpose of World Lung Cancer Day, as per WHO recommendation, is to create awareness among the culprits behind lung cancer. So awareness about the knowledge of lung cancer, symptomatology, don't confuse with the tuberculosis and all. Tuberculosis, we do a sputum microscopy. Easily we can diagnose within 2 days' time. Simple sputum microscopy we can diagnose. But the lung cancer needs a biopsy, bronchoscopy and all. So this way we can meticulously differentiate between other diseases from lung cancer. Once you diagnose a lung cancer, properly evaluate and we discuss with the oncologist team and give the proper treatment. So with this, we conclude the take-home message is very clear that every year in the August 1st, we do a lung cancer awareness program. The World Lung Cancer Day is mainly to create awareness among the populations and among our own medical professionals. So how to differentiate between the tuberculosis and malignancy, and what are the modalities of treatment. 20 years before, there is very minimal treatment options available. Nowadays, with the advent of oncology field is extending every day, we have a lot of targeted therapy and other therapy and all. So I request Dr. Suresh sir to give some take a message about for the lung cancer.
Yes, sir. Thank you, sir. So as he said, the treatment modalities have been extending and increasing day by day, thereby increasing the lifespan and the quality of life the patient will have once the patient has been diagnosed with carcinoma lung. Right from surgery, as I said, from lobectomy or a segmentectomy or to complete removal of the lung. Then we come to radiation. Radiation, it can be after surgery to consolidate the effects of surgery, or as a definitive treatment we'll be giving as a treatment, and also as a palliative treatment if at all the disease has spread to brain and bones. So these are all where conventional radiotherapy can be given. Right now we have advances in radiotherapy also with proton therapy. Proton therapy can be given if it's limited to the chest wall, within the chest wall alone. And as I have been earlier said, chemotherapy from the conventional, we have moved to targeted therapies with the tyrosine kinase inhibitors and the immunotherapy. So the lifespan, initially when patient was diagnosed with a stage 4 lung cancer, we expected from 6 to 9 months. Now it has been shifted, and we have been able to prolong the patient's lifespan with a good quality of life up to 2 to 2.5 years. So that is the advances which we have made with our treatment. So once you are diagnosed, don't get down, be positive, you can overcome the disease. That's our idea.
Thank you, Suresh sir. From pulmonologist perspective, I'll be giving some take-home messages to everyone. So lung cancer is a very common cancer. It mimics so many diseases. So any symptom like any cough, more than 2 weeks or 3 weeks, or any blood while coughing, don't neglect its symptoms and consult your family doctor or general physician or pulmonologist for the early evaluation, so we can do the proper evaluation. If necessary, you have to go for the CT scanning and bronchoscopy test. So this way we can diagnose the cancer lung very early to cure early. So early diagnosis is very, very important. Thereby we can prevent unnecessary complications and mortality and all. So lung cancer is the very commonest cancer. So every year, August 1st is the lung cancer awareness day, and the World Health Organization is clearly recommending that smoking is sort of the important factor behind the cancer lung, not only cancer lung, in the head to foot all the diseases. So each and every hospital has to have the smoking cessation clinic and lung cancer screening program. So we have the low-dose CT scan to diagnose the screen the cancer. This is not a gold standard. Still, we are struggling. So if we take the CA breast and CA cervix, we have effective screening program. But lung cancer, still we don't have a proper effective program. A lot of research is going on. So as per the WHO recommendation, any symptomatology like blood while coughing or any cough, weight loss, don't neglect, consult the medical practitioners immediately and do the appropriate investigation and take the treatment. So with this, I thank you everyone. I thank the MGM Healthcare. Greetings from MGM Healthcare. We have state-of-the-art facilities in medical oncology and pulmonology department. We have bronchoscopy and all other testing to diagnose, and we have a wonderful department of medical and surgical and radiation oncology. Thank you very much.
Thank you.
Thank you, Suresh.
Thank you, sir. Thank you, sir.